Assalamu alaikum. Good morning, everyone. My name is Dr. Srijan Kharel, and I'll be presenting on diagnosis of urinary tract infection, which is the second topic under genitourinary tract infection. And my moderator is currently Professor Asad. Now, learning objectives are classification, diagnostic workup, and general symptomatology. Now, first of all, urinary tract infection. Now, historically, finding at culture of 10 to the power 5 colony forming units per ml of a single organism was considered of having urinary tract infection. However, this misses 50% of the symptomatic infection, so the rate of more than 1,000 colony forming units per ml is now accepted. It is actually dependent on the method of collection, sex of the patient, and the type of bacteria isolated. Now, for example, if the collection is via suprapubic method, then the colony forming units showing gram-negative or any gram-positive organism of more than 1,000 colony forming units per ml have more than 99% probability of infection. Now, in catheterized patient, more than 10 to the power 5 colony forming units have probability of 95% of having infection, and less than 1,000 are unlikely of having infection. Now, in clean catch urine sample, more than 10 to the power of 4 are more likely to have infection. Similarly, in male patient, if the colony forming units is more than 10 to the power of 4, they are more likely to have infection. But in female patient, it's quite different. Now, if there is three specimen samples showing more than 10 to the power 5 colony forming units per ml, and 95%, they have 95% probability of infection. And if only one sample shows then more than 10 to the power 5 colony forming units, then they have 80% probability of infection. In cases where 1 to 5 into 10 to the power 4 are symptomatic patients and less than 10 to the power 4 colony forming units per ml are present, then they are unlikely of having infections. Now, classification of UTIs. It is based on clinical presentation, risk factors, and according to the source of infection. In clinical presentation, it may vary. It may be cystitis, pyelonephritis, or urosepsis. According to risk factors, the UTI may be complicated or uncomplicated. Now, according to the source of infection, the UTI can be community acquired or hospital acquired. Uncomplicated urinary tract infection of upper or lower urinary tract in healthy patient with structurally or functionally abnormal genitourinary tract, or in non-pregnant females are considered uncomplicated UTI. In these infections, microorganisms are usually sensitive to common oral antibiotics. Now, complicated UTI, infection of the upper or lower urinary tract associated with risk factors that increases the chance of having acquiring bacteria and having infection and decrease the efficacy of therapy. Now, urinary tract is structurally or functionally abnormal in such cases. Host is immunocompromised, and there is increased virulence or antimicrobacterial resistance. Now, UTI may either occur because of the pathogenicity of the organism, the susceptibility of the host, or the combination of both the factors. Now, factors associated with complicated UTIs are pregnant women, anatomical or functional abnormality of the urinary tract. In elderly patient, childhood urinary tract infection also falls under complicated UTI. Urinary tract instrumentation, hospital-acquired infection, symptoms for more than 7 days at presentation, indwelling a urinary catheter, renal disease, and any disease associated with reduced immunity such as diabetes mellitus, which is uncontrolled. Now, what is first or isolated infection? Now, these are the few terminologies which we are supposed to know. Now, infection in a patient who has never had UTI or has one remote infection or previous UTI are called first or isolated infection. Unresolved infection are those in infection that has not responded to antibiotics and is documented to be same organism with a similar resistance profile. Recurrent infection that occur after successful documented resolution of previous infection. Recurrence of uncomplicated or complicated UTI with frequency of at least 3 episodes per year or 2 UTIs in last 6 months. are also recurrent infection. Now, urosepsis, like any other sepsis, is a life-threatening organ dysfunction caused by dysregulated host response to infection, in this case, originating from the urinary tract or male genital organs. Now, domiciliary or outpatient UTI. Now, infection in a patient who are not hospitalized at the time when they got infection, these are usually caused by common bowel organisms. Nosocomial or healthcare associated UTI are infection in patients who are hospitalized at the time of infection. These are usually caused by antimicrobacterial resistant strains like Pseudomonas. Catheter-associated UTI. UTI occurring in a patient whose urinary tract is currently catheterized or has been catheterized within past 48 hours. Now, the classification of UTI based on anatomic site of involvement are grossly divided into lower urinary tract infection and upper urinary tract infection. In lower urinary tract infection, they can be cystitis, urethritis, prostatitis, and epididymitis. And in upper urinary tract, it may be pyelonephritis or presence of pus, that is pyonephrosis. Now, the diagnosis of UTI. Now, urine analysis for bacteriuria, pyuria, and hematuria should be performed, which is the basic in the diagnosis of UTI. Presence of numerous epithelial cells can indicate contamination. Now, dipstick test of urine. Now, first of all, dipstick is a thin plastic stick which consists of strips of chemicals coated in it. Now, this dipstick, as it is dipped in the urine, there are like various chemical reaction to the chemicals present in the urine, and they change color, which gives us ideas about the presence or absence of any components such as proteins or maybe blood, nitrites, and which gives hints towards the diagnosis. Now, they may show positive nitrile leukocytosis, but less sensitive than microscopic examination of urine. Microscopic urine analysis usually shows WBCs, bacteria, and occasionally hematuria in case of UTI. Pyuria and hematuria are good indicators of inflammatory response. Now, microscopic hematuria can be found in 40 to 60% cases of UTI, and it is uncommon if in other condition with dysuria, as it is more present in cystitis. Now, urine dipstick is cheap and rapid test. It can be performed on bedside of the patient. It's a totally negative dipstick test is associated with negative microscopy in 85 to 95% of the cases. That is, specificity is high. Now, in this picture, we can see the change in the color of the strips in the dipstick, which gives us hint towards the diagnosis. Now, examine the following urine analysis from patient G and H. Now, patient G has following finding: a dark colored urine with pH 6, specific gravity of 1.015, protein of 300 mg per deciliter, positive nitrite test, and the presence of WBCs. And in patient H, the following findings can be seen, where nitrite is negative, WBC is none, and there's no protein, no blood. Now, which patient likely has a bacterial infection? Now, anyone? Yeah, of course, it's G. Now we can see positive nitrite test, presence of WBC, also hematuria. Now, presence of bacteriuria has sensitivity of UTI of 40 to 90% and specificity of 85 to 95%, depending on a number of bacteria absorbed. Absence of pyuria should cause a diagnosis of UTI to be questioned until the urine culture is available. However, in genitourinary tuberculosis, staghorn stones, they can produce intense pyuria with clumps of WBC in presence of UTI. Now, urine culture in symptomatic patients, presence of 100 colony-forming units per ml or more indicates infection. Now, when uncomplicated infection is suspected, urine culture is not usually needed. In complicated infections, symptoms can range from mild cystitis to life-threatening urosepsis. In case of asymptomatic symptomatic patients who are uncomplicated, even routine urine examination and the history and the clinical examination itself can guide us towards treating the patient, maybe medical management. Diagnosis accuracy can be increased by proper collection of urine sample. In uncircumcised males, retract foreskin wash glands with soap and then rinse with water before specimen collection. Similarly, catheterization of male patient for urine collection is not indicated unless patient cannot void. In cases of neonates and infants, we have also seen using collection bag. We attach the collection bag towards in the around the genitalia of those patients with to properly accumulate the sample. We need to first clean the genitalia with soap and water. In those cases, in females, spread the lavia, wash and cleanse periurethral area with soap and water, and clean it with gauze, and then collect a midstream urine sample. Vaginal epithelial cells and lactobacilli can show contamination. In newborns and paraplegic, suprapubic aspiration is preferred. Again, collection bag also can be used properly. CBC. So leukocytosis with predominance of neutrophils can be seen as the infection spreads. Increased ESR, increased CRP can also be observed in urine analysis, as we have already discussed. To BC, bacterial rods or chains of cocci, granular or leukocyte cast can be seen. Urine culture, which is not done in all the cases, like I have mentioned, E. coli is seen in 80% of the patients. Now, blood culture should only be done in those patients with systemic toxicity requiring hospitalization or with risk factors such as pregnancy. The urine culture. The urine must be refrigerated at 4 degrees Celsius immediately on collection and should be cultured within 24 hours of refrigeration. Two culture techniques, like dip, slide, and agar, are widely used and accurate. In dysuric patient, an appropriate threshold value for defining significant bacteriuria is 100 colony-forming units per ml of a known pathogen. It is clinically useful to culture stones removed from urinary tract to document that the bacteria resides within their interstices. Now, these are the recommendations. So, diagnose uncomplicated cystitis in women who have no other risk factors for complicated urinary tract infection based on a focused history of lower urinary tract symptoms such as dysuria frequency, urgency, the absence of vaginal discharge or irritation. Now, this has good strength overall. Use urine dipstick testing for diagnosis of acute uncomplicated cystitis. They have weak strength, but this gives hints towards the diagnosis, and also the management can be based on this itself. Urine culture should be done in the following situations: when suspected acute pyelonephritis, symptoms that do not resolve or recur within 4 weeks after the completion of treatment, women who present with atypical symptoms, and pregnant women. Now, recommendations such as perform urine analysis using dipstick method, including the assessment of white and red blood cells and nitrite for routine diagnosis. Perform urine culture and antimicrobacterial susceptibility testing in patients with pyelonephritis. Perform imaging of the urinary tract to exclude urgent urological disorders, and they have all strong strength evidence. Now, recommendations: do not carry out routine urine culture in asymptomatic catheterized patient. Do not use pyuria as sole indicator for catheter-associated UTI, and do not use the presence or absence of odorous or cloudy urine alone to differentiate catheter-associated asymptomatic bacteriuria from catheter-associated UTI. And these all have strong strength. Now, imaging studies. Now, radiologic studies are unnecessary for evaluation of uncomplicated infection in most women. However, in high-risk patients, including women with febrile infection, and most men, radiologic studies may help in determining the cause of infectious process. UTI with possible urinary tract obstruction should always be evaluated in patient whose bacteriuria fails to resolve after appropriate antimicrobacterial therapy or who have rapid recurrence of infection. Abnormalities that cause bacterial persistence should be sought. Patient with diabetes mellitus, who can develop emphysematous pyelonephritis or papillary necrosis, polycystic kidney disease. Now, they should be properly imaged. Now, first, the ultrasonography. It is non-invasive, easy to perform. There is no radiation hazard or contrast risk. It is useful in identifying stones, hydronephrosis, pyelonephrosis, or perinephric abscess. It is also useful in assessing post-void residual urine. In right picture, we can see a normal right kidney with normal looking size, normal texture, well differentiated corticomedullary. Differentiation is can be properly seen. In left image, we can see a diffuse enlargement of the kidney. Corticomedullary differentiation is not properly seen, and the sonologist or the radiologist who perform ultrasound, they also can see probe tenderness. Now, starting from the left, we can see a dilated collecting system with echoes inside it, and enlarged kidney that is also grossly hydronephrotic, moderate to gross hydronephrosis can be seen. Now, that is pyonephrosis. We can see a middle picture suggesting chronic pyelonephritis, where we can see small atrophic kidney. There is no proper corticomedullary differentiation. There is increased echogenic texture of the cortex, which suggests chronic pyelonephritis. And there is additionally a cyst in the lower pool. Similarly, in the leftmost picture, we can see a grossly dilated collecting system with very thin and irregular cortex, suggesting xanthogranulomatous pyelonephritis. Now, CT scan. It offers best anatomic details and is more sensitive than excretory urography and ultrasonography in diagnosing radiolucent stones, pyelonephritis, and perinephric collections. Now, again, we can see like two images. In first image, in the left one, we can see that the right kidney is grossly swollen. And there is hypodense region of the cortex, which is a typical picture in acute pyelonephritis, whereas the left kidney is normal in that image. In the right image, we can see the right kidney is small, atrophic, with irregular margin. There's patchy area and also low contrast optic as compared to the left kidney. That's suggesting chronic pyelonephritis. That's the CTI view. In left image again, we can see the gas inside the kidney reaching up to the parenchyma, as grade 2 emphysematous pyelonephritis. Now, this classification was given by Wang and Ling. And similarly, in the right picture, we can see there is a grossly dilated collecting system with very thin cortex, which is irregular. And this gives appearance of typical bear paw sign, which is seen in xanthogranulomatous pyelonephritis. Now, radionucleotide studies can also be done. In this image, we can see a DMSS scan that is done, which shows a decreased isotope uptake, mostly in the upper pole, suggesting that there is like damaged parenchyma of the cortex in that region. Mostly done in cases of chronic pyelonephritis to see if the kidney is functioning properly or not. Now, voiding cystourethrogram is an important investigation for assessing vesico-ureteric reflux, neurogenic bladder, and also paraurethral diverticulum, and the patient which results in persistent infection. In this image, we can see left side grade 5 VUR, where there is like excessively dilated and tortuous collecting system reaching up to the ureter and the collecting system in the kidney. There is blunting of the calyx as well. Now, general symptomatology. Now, we need to first know how the urinary tract infection occurs, as it was beautifully explained by Dr. Yamuna in previous class. Now, it may be ascending infection, which is the most common, or hematogenous spread, lymphatic spread, which is less common, and also the contiguous spread from the surrounding organs. As they travel to the bladder and then reaches the kidney, can cause symptoms and infections ranging from cystitis to pyelonephritis. And this leads to cluster of symptoms ranging, depending on which site is affected. Can be pelvic pain in case of cystitis, or back pain in case of pyelonephritis. And there may be fever, nausea, vomiting, hematuria, and burning sensation while urinating, and as well as other irritative symptoms such as frequency, urgency, nocturia. Dysuria can also be present. Now, the presentation again, like I mentioned, differentiates different in lower urinary tract infection and upper urinary tract infection. In lower urinary tract infection, the symptoms ranges from dysuria, urgency, lower abdominal pain, low-grade fever. Whereas in upper urinary tract infection, dysuria, urgency, acute flank or back pain can be noticed, along with fevers, chills, and extreme fatigue. Now, in physical examination of the urine, we can see possible blood tinge color, pink, red, green, from rare Pseudomonas infection, mostly seen in, again, like I have mentioned, in hospital-acquired infection. Strong odor, cloudy orbit, and the same finding is seen in the upper urinary tract infection in the urine. In chemical tests, positive leukocyte sterase and nitrite from gram-negative bacteria can be noticed. Now, small amount of blood and protein are possible, and again, the same finding in case of upper urinary tract infection. In microscopic examination, there are many WBCs, RBCs, microorganisms, transitional epithelial cells, but there are no cast or few abnormal hyaline casts in case of lower urinary tract infection. But in upper urinary tract infection, beside all these symptoms, all these findings, they may also include renal tubular epithelial cells and WBC incorporated casts. Now, this was the summary. Thank you.